How's it going, guys? Medium difficult question, micropharm step one. 29-year-old dude with HIV who does not have pneumocystis jirovecii pneumonia because it's not bilateral. It's one of the most basic high yield points for USMLE that they give you CD4 count under 200. They don't say anything about trimethoprim sulfamethoxazole prophylaxis for pneumocystis, but OMG, it's a low bar pneumonia. That's strep pneumo, not pneumocystis. Pneumocystis is a ground glass bilateral pneumonia. Very basic pass level detail, but we asked you a little bit more involved stuff about the Pharm, so we could argue it's a medium difficulty question. And just to be very explicit, I said acute presentation here, which we're talking specifically about the pneumonia, even though, yes, he would need to be on TMPS mix prophylaxis. We're asking about the strep pneumo empiric therapy. So let's just hop through. Choice A, 30S, wrong fucking answer. Aminoglycosides, tetracyclines, could do 40-minute discussion, all the use cases, side effects, etc. Aminoglycosides, gentamicin, tobramycin, amikacin. So gentamicin paired with vancomycin classically for empiric therapy for endocarditis. Aminoglycosides, acute tubular necrosis, ototoxicity. Ototoxicity need not be hearing loss, can be vertigo, the room is spinning. Tetracyclines, such as doxy, Rocky Mountain spotted fever, Lyme disease. Phototoxicity in adults can cause tooth discoloration in children. Choice A, wrong fucking answer. Choice B, 50S, correct answer. Azithromycin, standard empiric therapy for outpatient community-acquired pneumonia. They ask it straight up on one of the 2CK forms. So as I just harped on, this is strep pneumo because we have a lobar pneumonia. It's not bilateral, so we know it's not pneumocystis. Macrolides can cause GI disturbance. Patient has upset stomach, diarrhea, constipation. Can also prolong the QT interval. Other 50S inhibitors, clindamycin, chloramphenicol, linezolid. Let's just hop through the others here. Choice C, very verbose hydrofolate reductase dihydropteroate synthase, refers to trimethoprim sulfamethoxazole, but we're addressing the acute presentation here, the pneumonia, not the prophylaxis needs to be on for PJP. So dihydrofolate reductase, not just for trimethoprim, but also the mechanism of action, the inhibition for methotrexate and pyrimethamine. And then dihydropteroate synthase for sulfonamides. Choice C, wrong fucking answer. Choice D, DNA gyrase, aka topoisomerase 2,4 prokaryotic, wrong fucking answer. Okay, so fluoroquinolone, ciprofloxacin, levofloxacin. The latter is a respiratory fluoroquinolone that some of you who are hyperpedantic will say, well, can't fluoroquinolones also be used as empiric therapy for outpatient pneumonia? The answer is yes, but they're typically not first line because hospitals worry about resistance, and also the patient has no recent history of antibiotic use. So if we said the patient had antibiotic use in the past 3 months, that could imply that we will use a respiratory fluoroquinolone instead. I've never actually seen NBME material for 2CK assess this point. It's just textbook, okay? So you could just be aware, levofloxacin has greater pulmonary parenchymal penetration. It's known as a respiratory fluoroquinolone, and it technically can be used for empiric therapy for community-acquired pneumonia in patients who have history of recent antibiotic use. But on the 2CK NBMEs, they ask azithromycin. You need to be aware that fluoroquinolones can cause tendinopathy, more specifically Achilles tendinopathy, usually occurs in males over the age of 60 who have renal insufficiency with recent oral steroid use. Choice D, wrong fucking answer. Choice E, diala, wrong fucking answer. Refers to vancomycin target, okay, cell wall synthesis. So diala goes to D-lac, mechanism of resistance to vancomycin. As I mentioned before, vancomycin can be paired with gentamicin empiric therapy for endocarditis. Vanc can be paired with ceftriaxone empiric therapy for meningitis. And if we're talking about a nosocomial infection, hospital ventilator required, then Vanc can be paired instead of with ceftriaxone, with cefepime or with ceftazidime. Those latter two will cover Pseudomonas. Choice E, wrong fucking answer. You know the deal. I'm to make more content. If you like my stuff, subscribe my channel. Appreciate your time. That's it.